so my name is Jessica. I'm the Director of Research at a small inpatient addiction treatment center up in Long Island called Wellbridge. I'm so happy to talk to you about really how to close the research to practice gap using a prevention lens. So before we get into it, I kind of want to give you a sense of what Wellbridge is. So Wellbridge is a small addiction treatment center up in Long Island. So this is our wonderful 95-acre campus. Most researchers do not get to study patients who are struggling with addiction unless they have the opportunity to write a grant, to have that grant funded, and even then, they're usually not physically on the campus. So I am part of a very small team. That's my wing right there, the Center for Addiction Science. That's all mine, and I love it. And then they started putting finance people in it, and it was lovely as well. We love having the company, but I was a little upset that all my territory was being taken away from me. There were more people to share the bathroom with every day. But to give you a sense, right here in front, this is our detox wing. So I can walk 10 feet down the hall, and we have our patients who are stabilizing. Above that, that's our rehab wing, where everyone lives during the 30 days after they detox. Over here, this is our cafeteria. Behind there, that's our auditorium. And then we have this lovely holistic center out front. We have our center for our creative arts center, our gym, and then our residential wing, which isn't currently open, but we have plans to open it, and we currently serve groups there. So again, I wanted to give you this visual to highlight exactly where I work every day and highlight just how unique it is. But with that said, this is a very unique opportunity. It doesn't mean that what I have to share with you today doesn't relate to you and your situations. In fact, being able to dive in gives me more insight and hopefully more action-oriented tips to offer all of you. So we're going to start by orienting you to what the research to practice gap is. And so we're going to spend a few minutes talking about that and walking you through it. Then we're going to hit prevention science, which I know most of you are aware of. So I'm going to throw it at you from a slightly different perspective. I'm going to throw some of the genetics in there, but it's not going to be scary, I promise. And the third thing here is really the bulk of where we're going to spend our time, where I think a lot of you will hopefully have something to take away. So again, the third thing, using science to close the gap, that's the action-oriented perspective that I'm talking with. So I'm going to end with these 8 tips that I really hope all of you can think about and kind of ponder throughout the rest of your time here. And then we'll end with some final thoughts. So before we get into it, I always like to orient people to remind us, why do we do this, right? So you can call it out. So first question here, what percentage of US adults have used any illicit substance in their lifetime? What do you think it is? 90, I heard 91, what else? 75, ooh, every time I've practiced, everyone's gone with 75. It's actually 53. It's actually, yeah. So about half of US adults have tried some level of illicit substance in their lifetime. What about alcohol? How many people do you think have tried alcohol in their lifetime? 54? Shh. 84, ooh, ding, 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 good job. I wish I had candy for you, I'm so sorry that I don't. So exactly, so 84%, right? So these are all the people using substances in our lifetime as of the SAMHSA 2022 data, which is last available data that I could get my hands on. But not everyone who uses substances develops a substance use disorder. And I bring this up because that's where prevention comes into play, right? That's where all of you in the room come into play. Yet, 17% of the population is still millions of people that we're talking about. So from the treatment perspective, we still have a lot of people that are in need, a lot of people that need help. But the good news is that prevention is still doing a lot of the work, which is fantastic. So how can we keep that up, right? How can we keep closing this research to practice gap? So let's talk about what it is, why it exists, and how it really kind of manifests in our organizations. Because again, even if you don't work at a place like Wellbridge, even if your organization looks nothing like it, I'm sure that some of what I have to say is relatable. So what is the gap, right? It's somewhat self-explanatory. So the research to practice gap is a term that we use for a phenomenon that really exists across all of healthcare. It means that a lot of the science and the research that's being done isn't really making its way into practice, right? So this can really manifest in outdated treatments for patients. Patients aren't getting optimal care, and a lot of other negative outcomes that we'll get to in a few slides. But it's especially bad in addiction treatment. So the flip side of that is that the clinicians, all of you in the room doing the work, medical providers, clinicians, social workers, even teachers, practitioners, you might be trying out something new in your clinics. You might have this fantastic way of doing therapy, this fantastic new treatment that seems to be working for a certain type of patient, but there's no way to really study it, right? You don't have me down the hallway to kind of study that for you. So that means that the great things you're discovering also can't really be tested. And I use the term research to practice very specifically. I want to be clear that given my vantage point, I mostly only study and work with the relationship between me and my team of researchers and scientists and the medical providers and the social workers and the psychiatrists and psychologists at Wellbridge. But this gap exists across all of the stakeholders, right? So there are so many gaps between the communication of patients, their family members, insurance providers, administrators, researchers, medical providers, nurses. All of us do a really bad job of talking with each other. And so in the long term, I really want to close all of those gaps. But the one that I really wanted to start with in my career is the one between researchers and practitioners. So why does this exist, right? So there's three main reasons that I'd like to highlight as to why this gap exists. So the first one, it might seem like a little bit of a softball, but it's a really complicated problem. It kind of comes from complicated origins, and therefore it's a little complicated to solve, right? So it's really not as easy as saying, okay, all you great researchers, just do a better job communicating, right? Go on social media more, go do talks like this more, make your papers more accessible. It's not that easy. It's also not as easy as telling all the practitioners in the room, hey, go online, pay $50 for an article that may relate to a patient that you have at the moment, and then just throw your money down the drain doing that. It doesn't get us in the room together. It doesn't actually close the gap. In many ways, you could argue that that just further expands the gap. The second reason is that the addiction landscape, the addiction treatment landscape, largely developed outside mainstream medicine and science. So as you all know, about 100-ish years ago, we have AA, NA popping up, and then over the years, we have SMART, we have Dharma, we have Women for Sobriety, all these fantastic resources that to date remain the #1 place where patients go when they're in need. Due to the criminalization of not just people who use, but of people who want to help people who use and people who want to research it throughout the 1900s, that really meant that we lost decades of research. We lost decades of medicine. So that means that research and medicine are still largely catching up, and this has significantly contributed to that research to practice gap. And then the last reason why the gap exists is one that we all know, but I think it's one that bears reminding. I myself, on that beautiful campus, often forget how real the stigma is for our patients, because Wellbridge is a fantastic place. It has its flaws, but one of the flaws that we have been very mindful about is that we serve all of our patients from a judgment-free, human-focused, humanistic perspective. So it's very easy to go to work and forget the shame and the stigma that our patients face every day. So and I think that probably some of you can relate to that. You don't hold that shame and judgment in yourselves, but you might work with other people who do, or you might go to the doctor, go to a practitioner, and then it kind of comes out. And so this is really the main reason why this gap still exists. There's a lot of practitioners that go to med school and they say, I don't want to deal with patients with addiction. As Jan pointed out yesterday, they might get 4 hours of training in a psychiatry rotation on what addiction means. So sometimes it might not even be shame or stigma. The system is set up so these people don't have the competence to even treat patients with addiction. So how does this manifest, right? How does this come out in our organizations? So what you see here is based on research largely more in like psychiatry as a whole, but I think it largely relates to addiction. I think that you'll get something out of it. And I think you'll be able to relate to a lot of this. So how is this perpetuated? One reason that the research to practice gap is perpetuated is that a lot of the times that we think what worked before is just gonna keep working, right? So in genetics, this tends to come out with people saying, oh, a lot of the breakthroughs we've had at a cellular level for cancer, for diabetes, those have been fantastic. So let's pick those up and copy and paste it, and let's have it work for psychiatry. Let's have it work for addiction. And then guess what? It doesn't work because these disorders are different. But people don't want to think up a new way of solving it, so they just keep doing the same thing that doesn't work over and over and over again. More specifically to addiction, it might come out in the sense of maybe there's a CBT, maybe there's a certain CBT group that you have always done for your male patients who present with opioid use disorder. And it's always worked, always worked, always worked. And then one day it just kind of stops working. And you're like, oh, it must be the patients, right? I'm not going to bother to figure out a different treatment, a new treatment, try something new. What worked before surely is going to keep working. The second one is relying too much on very specific types of data and specific types of information. So again, in genetics, this often comes out as, even when I said the word genetic, you all immediately thought of blood, saliva, 23andMe, right? That's not actually the type of genetic information I work with. I focus more on family history and non-genomic information. But a lot of people don't immediately think of that, so it kind of gets pushed to the side. In addiction, the way I see this play out at Wellbridge, and again, some of you might be able to relate to this, is we all have our biases. So if you're the intake coordinator, if you're a social worker, you're going to rely on the biopsychosocial more than you're going to rely on the UTOX. But the medical provider and the nurses are going to rely on the UTOX and the COW scores and the CEBA scores that come in, right? So we have a hard time putting all the information together and using all the information in a holistic way, and this keeps perpetuating the gap. Another one is we prioritize certain disorders. I think this one very much is self-explanatory. Even think about the second slide that I showed of like the questions that I had for you. Substance use disorders and alcohol they were separate, right? Alcohol is very much prioritized in this field. You could make a lot of arguments for or against that, but it doesn't change the fact that it is. And it means it gets a lot more money, it gets a lot more attention. Opioids are starting to catch up, but cocaine, sedatives, amphetamines, those don't get nearly the same amount of attention, and that keeps the gap perpetuating, especially for those disorders. So this is my favorite, not enough action, right? So even if you can't relate to the first three, I can guarantee you that you can relate to this one, because I can guarantee you that you've been in a meeting where people are droning on and on and on, and they're just identifying a problem. And you're all complaining about the problem, like, yeah, that's definitely an issue, right? And then you leave the meeting and you're like, yeah, I'm worked up. Yeah, that's a big problem. Do you actually go solve it? Did anyone actually have a solution for it? No, probably not, right? So this is a really big reason the research to practice gap exists. If you're a researcher in the room, I know that you've read an article where it kind of ends with that obligatory statement of, yes, and this will impact clinical treatment someday. Yeah, see, you know what I'm talking about. And you're like, okay, but when? I've been reading these statements for 15 years. Like, when is that going to change? And then the final one is the lack of education, as I sort of got at earlier. Because at the end of the day, we need to do a better job of having addiction be part of the training, of the competency of practitioners, of social workers, of psychiatrists, of psychologists, of researchers. Because a lot of the time they don't know enough about it. So a lot of the fear of not wanting to study or to work with patients who struggle with addiction might not be coming from judgment, it might just be coming from lack of knowledge of how to treat the disorder. How does this play out, right? As promised, how does this play out? Underutilization of effective therapies, right? With contingency management being one of the biggest. We know this works and we don't use it nearly as enough as we should. Utilization of outdated therapies as well. Fewer professional development opportunities. Again, we need more opportunities like this to bring everyone together, to get everyone in the room. Lack of a science-based focus. This is going to be a big theme throughout the back half of the presentation because we can't just have a wild, wild west situation, right? We need to be very mindful of how we go about closing the gap. Uneven quality control. Ooh, this is one that is one of my favorites, but in practice, I think a lot of people don't actually like it as much as I do because it means we need to take a look at ourselves and hold a mirror up to ourselves and say, are we actually doing as good of a job as we could be doing? Lack of comprehensive and interdisciplinary care. So again, like we want everyone to be on the same page. We want to check our biases at the door. And then treatment isn't reaching all marginalized communities. This is one that most of the other speakers throughout today and tomorrow are going to get at. So I please encourage you to stay and pay a lot of attention to those talks as well. So let's kind of pivot to prevention science, and then in the last section, we're going to put it all together. So for those of you who don't know, prevention science is, I kind of describe it as a translational science. It's a way to close the research to practice gap, really from a public health perspective. That's really where it comes from. And it has a primary, secondary, and tertiary levels. And so we're gonna quickly review what those are, but I'm gonna try to do it in a fun way. So I told you the genetics would be back. So here we have mom. So mom is a 45-year-old Hispanic bisexual woman who presents to Wellbridge with severe alcohol use disorder. You see her immediate family here, right? She has a husband, she has 3 kids, all the grandparents are still alive. So you think, okay, prevention science, we're probably gonna just be focusing on the kids, right? Like they're the ones exposed to the alcohol in the home potentially. They carry the genetic load that mom gave them. Yeah, that's part of the picture, right? But it's actually not the whole picture. So when we zoom out and think about prevention science, we actually want to think about mom's entire network. And again, we actually want to think about everyone, but let's just think about everyone in mom's circle, right? So with mom, we have her book club friends, right? They call themselves wine moms. We've all heard of this. It's gained a lot of popularity over the years. So this is a known alcohol exposure for her. So once a week, they all get together, they drink a few drinks, they have a few laughs. So not only do we know that's affecting mom, but we actually don't know the risk that that's also giving to her friends as well. Her husband's coworkers, she doesn't know them that well, but they go to social events together. There may or may not be alcohol or other substances there, so we don't really know what type of exposure, what type of risk they're also carrying. Her children's friends, they come over to the house. They're young, they're impressionable. Who knows what they see and who knows what other exposures they have in their home lives as well, let alone what they're getting at mom's house when they come over. Neighbors, you do the barbecue thing. Maybe you share a little bit of cannabis on the side. Who really knows what's going on with the neighbors? But again, that's kind of the point of prevention. We don't always know what's happening, so we're trying to target as many people as possible. And then college friends. Let's just say that we know they use heavily. Not really sure about alcohol, but we know they use other things heavily. Unclear how much that's influenced mom. So when we get to primary prevention, we want to target everyone. So we're targeting everyone in mom's social circle, including her family, right? Because the goal of primary prevention is a lifestyle change. We want to prevent the disease from occurring. So how might this play out, right? Think about VCU. We have lovely stall seat journals. You also have those Truth Initiative. They're based in DC, right? Who remembers like the licking the trash can commercials? So like things that really stick with you, things that we've all seen. Also counseling services for general well-being, or even going to your primary care physician, right? They're going to be asking you screening questions about depression, about alcohol use, about substance use. That's all part of primary prevention. That's all trying to get at serving everyone. So how does this play out at Wellbridge, right? Just to use Wellbridge as an example. So even though we're a treatment facility, you might think, okay, you're not really in the prevention business, but we are. We have to be, because again, we're trying to close that research to practice gap on a daily basis. So we go out into the community, we do Narcan trainings. We've gotten into high schools lately, and that's a fantastic opportunity for those high schoolers to learn more about addiction and to also give them those resources. We also present at conferences like this, and a lot of my colleagues are currently at a conference, I think in Nashville, presenting on very similar topics, right? About a program that we'll get to towards the end of this talk. So we go out there, we try to spread the word. It's not really self-serving about Wellbridge, it's about trying to help educate people about addiction, trying to close this gap. And of course, we do little soft things like newsletters, fact sheets, things like that, which I think a lot of us delete when we get them, but they're still part of the puzzle. They still are necessary for primary prevention. So what about secondary? So who are we talking about with this? So we're talking about people at risk, right? So we're talking about mom's kids, obviously, maybe the book club friends, maybe the college friends. So here, we're really trying to connect people to services, maybe, again, result in some type of lifestyle change to keep the disease from either getting worse or becoming a full-blown severe use disorder. So what are things we can do to kind of capture this, right? We can use health assessments at a behavioral level, maybe at a personality level. We can do family history analyses or social network analyses, which is something we'll get to towards the end with some of the actionable tips, and even early identification of chronic disease. So if you're from a medical perspective, maybe looking at liver enzymes or yellowing of the skin, neurological changes, things that might indicate that there's a disease developing. So how does Wellbridge do this? So we have a huge emphasis on family services. We have a huge emphasis on connecting to the family. We have a robust family counseling opportunity and group families. So we also have opportunities for families to come onto a Zoom call together and kind of process what's happening. We also haven't had the opportunity to start this, but we have plans to really create a robust group around the children of our patients, which again is probably one of the main groups that we need to target from that secondary prevention perspective. And of course, we have the ability to conduct family history and social network analyses, which we'll get to later. So then we have tertiary. So now we get to mom, right? So it's like we kind of start out with mom. We're like, okay, mom's the one presenting, mom's the one who's sick. But guess what? It wasn't all about mom the whole time. But now we're finally getting back to her. So now with tertiary prevention, the goal is to prevent relapse, right? The goal is to slow down the progression of the disease. And this can look so many ways, right? So it can be CBT, it could be DBT, it could be family therapy, it could be medicated assisted recovery, of course, lifestyle changes to support recovery, because we know that recovery is more than just staying sober. It's an entire approach to well-being. And obviously utilizing assessments, right? So again, I'm kind of priming the pump here for things that we're going to get to in a few minutes, but maybe helping mom understand what are her triggers, what's her self-efficacy, what's her motivation for using, and try to help sort through that in therapy and in her life. So obviously this is the main thing that we do at Wellbridge. Again, getting back to Wellbridge as an example, right? So we have comprehensive assessments. We have medicated assisted recovery. We have a lot of evidence-based protocols that we utilize. So like this is our bread and butter. This is the main thing that we do. We mainly focus on mom in this situation from a tertiary prevention perspective. But again, we do our best to help everyone and to really try to hit all levels. And so I'm going to pause. Like, I'm very curious. I want to hear, how do all of you engage in prevention? Is it primary? Is it secondary? Is it tertiary? Is it both? I want to spend like a couple minutes kind of thinking through this and digesting this before we get to the action-oriented part of the talk. Yes?
So I'm with Intercept True North Clinic, which is in Richmond and Roanoke. And we actually do some prevention groups with adolescents.
Perfect.
So we work with some of the local school systems and we'll take kids with them that might be caught vaping, as simple as nicotine vaping. And of course, a lot of times we found out there was a lot more going on than that, so it's kind of that entry for them. But we do it that way. We're also involved with our local, it's called RACIC, and I wish I could remember right now what that stands for, but it's a youth substance abuse coalition, which is prevention, so we are also involved on their board.
Perfect. So thank you for sharing. So it's okay if there's a couple acronyms and I'm probably not going to remember them either later on. So yeah, so focusing on adolescents, right? Especially nicotine, especially vaping. I know, is Linda still in there? Like, I know that when I was here, that was something that was like a big thing. It was getting very big. Linda called it, right? It unfortunately exploded way beyond anything we could anticipate. And it's honestly a big problem among the adult population at Wellbridge as well. I actually tried to do a smoking cessation study with the patients and they didn't want to do it. And I was like, you're getting paid. I'm not telling you to quit. I just want to like understand how we can help you quit. And they were like, nah. I was like, okay. Anyone else? Anyone else engaged in prevention? Anyone else who like, this is like your bread and butter?
Yeah, how do you bring the family into treatment and those who were impacted by the disease of addiction? And what does that look like?
It's a great question. So it looks like many things. So we try to engage families as soon as we can, especially for patients that are at risk of leaving against advice. And so we firmly believe that if we can get the family involved, we can divert a lot of that, and we can actually keep them in treatment. And so from day one, we're connecting with the spouse or the family or the daughter, the son, whoever is involved in the person's life, trying to set up a family therapy session. And so we have a very robust manual that we follow, but sometimes we don't have time for that, right? It's like a 7-session manual. It's based on years and years of evidence, but guess what? Sometimes it's just a collateral call. Sometimes it's just a phone call with the patient in the room on speaker, with their spouse on the speaker, just to say hi, just to make sure that they're involved. And a lot of the time, we can leverage the family to keep the patient in treatment. But that doesn't always work, right? Sometimes people in the family are using. So sometimes the family's a trigger. And so that's where the rest of therapy really comes into play. And sometimes you have to have hard conversations about what environment are you going back into? And how is that going to influence your recovery? And that's, again, where comprehensive assessments come into play, where really having honest conversations with the patients come into play. And then, of course, what I mentioned earlier, having, I think it's every Tuesday or Wednesday evening, every other week, patients can, or their families can log into a Zoom, current and former family members, and just have a process group.
So I just wanted to highlight the bikes that are up at the front, and I think the Narcan bike's somewhere around. But this is a campus initiative where they just take the bike out onto campus and teach people how to administer Narcan, have conversations over coffee, see the books. I also was noticing there's several people in the room with the Suicide and Crisis Lifeline on the back of their shirt in the teal. So those are all initiatives.
Thank you. No, I really appreciate you pointing that out. So VCU's grown a long way. Yes, hi.
Hi. So how do organizations move from just a territory prevention orientation to a more primary and secondary prevention? We do
I think tertiary,
There
it
you
feels
go.
like a typo, yeah. Like an autocorrect issue.
at my program, but nothing regarding primary or secondary.
So I think it's a great question. I think that it's just about being mindful and not thinking that anything is too small. So even going back to the things that we do for primary and secondary, they're not a big bulk of what we do, but they're definitely part of the mission. So things like what Mary was saying, like just have Narcan training, have suicide prevention, it could be as simple as a newsletter, right? It could be as simple, I don't know the organization's person works, but as simple as trying to connect with families, getting back to the gentleman's question a couple minutes ago. So I think just being mindful of kind of where you want to focus most of your efforts, and can you kind of take 10 or 20% of that effort and put it towards the other levels of prevention to try to get at everyone. Anyone else? Otherwise,
Yes, ma'am. From a peer perspective, I think it's secondary because we get referrals from clients, consumers who've already engaged. So working with the prevention department as well, I think it's a secondary, it's a reactive instead of proactive with someone under 18. Because right now with peering, we can't actually, and I applaud you for getting into schools and all of that to talk to the kids, but we can't. In the realm that I work, it's adults and it's referrals and it's secondary as far as the peer team that I associate with.
no, I appreciate you bringing that up, and thank you. I mean, peers are so important. We hire peers at Wellbridge. We always have a robust team. But you're right. Like, it's a very different type of work. It's very much at that secondary level. And our peers, we had a patient who unfortunately relapsed. I mean, it's getting more tertiary, but I think it comes to mind with what you're saying. And he didn't want to come back to treatment. And he was in the local hospital. And there was no agenda, but the peer was like, I've worked with him for years. He's in and out of Wellbridge. I'm just going to go say hi to him. And he ended up coming back to treatment, which was fantastic because he's someone who's very, very sick. And just that touch point made a huge difference, hopefully, in his recovery journey. All she did was show up, say hi, sit with him for a few hours, and go buy him a cell phone charger. And sometimes that's what peers do, and sometimes that's enough, right? So thank you. Okay, so we have talked about what the research to practice gap is. We've highlighted prevention. We're all on the same page of what prevention is. Most of you in the room really work in this space. So how can we now kind of take what we know about the gap and apply a science-based approach to really solving it? So what I have here are 8 tips, 8 very actionable tips, some of which are, have been published, like things I've been very actively working on during my time at Wellbridge. So we're going to go through these for the last little half of the presentation. So tip number 1 is to create a learning laboratory culture. So this also gets back to the online question as well. This is very simple. It's a little soft, but it's sort of like the umbrella for all the other tips because you need the culture to be in place. And I'm not going to say that this is the easiest tip. It's actually the one that's been the most ongoing for me and probably one of the most challenging. But you have to do it, right? You have to create a culture where everyone buys into closing the gap. Because when you create this culture, you can increase scientific rigor at your organization. You can increase the trust that patients have in the scientific process because a lot of patients don't trust the scientific process. They don't trust doctors, they don't trust researchers. You can, again, improve that research practitioner, research clinical line of communication. And of course, create that interdisciplinary culture. So I don't have anything more specific than you for that with this particular tip, but know that all the others are sort of subsumed by this one. So tip number 2, so I kept promising and hinting at assessments, and this has really been the bulk of what I spent the first 2.5, 3 years of my time at Wellbridge doing, was working on comprehensive assessments. So these are assessments that go well beyond a biopsychosocial. They go well beyond an intake assessment. They are really designed to shave 1 or 2 sessions out of a therapy one or 2 therapy sessions out of a patient's time, which at an inpatient level of need, with 28, 30 days, shaving 2 sessions out, that's actually a lot. That actually buys you a lot more time with that patient. So what do our assessments do, right? So we go very deep into substance-related metrics. We go very deep into abstinence-related emotions like cognition, things that we know are highly related to recovery and long-term recovery outcomes. So things like desire, motivation, self-efficacy, your confidence use. Things that might seem very obvious, but if you actually looked at a biopsychosocial, these things aren't in there. Because the biopsychosocial is, at least in New York, it is dictated by our licensing body. So there's just a lot of questions in there that may or may not really relate to treatment, right? We also get at well-being. Again, something that we know is so integral to sobriety, but how many biopsychosocials actually get at well-being, actually have a score that you can measure and kind of track throughout patients' time and maybe even have subscales to know which part of the well-being is a little weaker or a little stronger. We get a social network and family. We have the ability to do a psychiatric screening. And then for some of the assessments, we actually get into quality, which is really important, right? So we see patients at the beginning of their time here, in the middle, at the end, and then 2 times after they leave. So we're very much into the outcomes world. We want to know how our patients are doing long after they are at Wellbridge. But that's me, right? So you could be sitting here thinking, okay, there is no way I have 6 months of time to follow the patients. And guess what? It's really hard. They do not pick up the phone. I've gotten 10 post-assessments in my 3.5 years. But the 3 months really, really work. That's a good way to connect people back to services. Or if you can't do that, just do a baseline. Just do an endpoint, right? Just do something else. Add something else into what you do to make it a little bit more comprehensive, to help you dig a little bit deeper at the beginning of their time here. But it wasn't just enough to set up the assessment. So something that I did is I really wanted to avoid saying, hey, I'm a researcher. Hey, I think I know best. Here's a bunch of assessments. Here's a bunch of numbers and data. Go use it. That was not the approach. So this took about a year, and we were able to publish a paper that highlighted the process of which we went about creating not just the assessments, but the report that we use to communicate that to the clinical and medical teams. So hence, really actively closing that research to practice gap. And so I highlight this paper because you can go online and you can see the version of the report that I'll kind of show a couple of screenshots of in a minute. You can take it, you can use it. We publish for a reason. I want people to really learn from what we've done. So It's now in patient's medical report, but the last version that was like kind of a word version ranges 0 to 10, checkboxes, confident, not confident. So we're breaking it down in very digestible ways for clinicians, and clinicians were part of the study. They gave us feedback on every version. So this is version 5, and this was translated into their medical record. So again, like with psychiatric, you kind of highlight the illnesses that are popping up and that they need to be screened for, social network at the bottom. So again, the point isn't to like read this in depth right now. The point is that this is fairly easy. If you were to get this, you could look at the check boxes fairly easily. In 10 or 15 minutes, you could have all the information that you needed, circle back to me or my team if you needed to. So again, to kind of wrap up this particular tip, comprehensive assessments are inpatients charts, right? It goes beyond a BPS, it goes beyond an intake assessment, and it's really utilized in treatment. So I kept kind of talking about clinicians, but you can also utilize it in utilization reviews. I don't know how many of you are involved in the insurance process, but insurance is awful, as I think we all agreed yesterday. And some insurers are better than others. But again, if you don't have enough information to keep a patient at your facility for more than a few more days, something like this can really, really help. And it also can inform the discharge plan. A lot of the information we collect might not be immediately actionable because again, like when a patient presents, especially to an inpatient center, we're really focused on like medically stabilizing them and kind of starting to understand why they're here. So a lot of the information gathered might need to be picked up by outpatient, might need to be picked up by their outside psychologist as well, and that's where a really good discharge plan comes in. Tip number 3, right? Quality control. So this is I know that you've all seen versions of this. I like to think of assess, plan, implement, evaluate. I think it's also called like see, plan, act, do. This is a model that needs to be the backbone of your work, whether at your individual level, your department level, your organizational level. It's a way to really hold our feet to the fire when having good quality control for our patients, because good quality translates into closing the research to practice gap, and it translates into better care for our patients, because our care should always be safe, effective, patient-centered, timely, efficient, and equitable. So this is something that's really hitting at all the prevention levels, kind of depending on where you're at and what you do within your organization. High quality affects everything. So what I do, just as an example, I do monthly and quarterly reports. I mean, what you see on the right is just a screenshot of the cover page, and this takes a long time. You know, it's not the most fun thing I do as part of my job, but it's something that's very necessary because I'm trying very hard to avoid the file drawer, right? Where we are collecting tons and tons and tons of data and information, and then it just sits in the metaphorical file drawer. It's really just like a OneDrive. Like it's really a cloud these days. But nevertheless, you understand the point. We want to utilize this information. So what I do is when I write my report, we're keeping an eye and making sure that like the patients on the assessment scores and metrics, they're staying where they should, right? No one, like no particular cohort is kind of outside of anything we would expect. But we're also getting at the quality. We ask a lot of very department-specific questions so that we can make sure that we can improve in an iterative way without being reactive. So what do I mean by that, right? How many times have you been at work and a patient comes up to you and they're like, I hate the food. You're like, okay, fine, we'll have eggs tomorrow. Like, I'm sorry you hate it, right? So we get a lot of that. I've witnessed a lot of that at Wellbridge, and that started to change with a lot of these department-specific quality control questions that patients answer every day as part of my team and that I provide every month and every quarter to the department leaders. That way we can make sure that we know kind of what are the trends of what need to be fixed, what are the general weak areas, and how can we do that in a really strategic, scientific way, not in a very reactive way. So tip number 4, this is one that's probably one of my favorites, and if you're a clinician, it's gonna be your least favorite. Well, that's been my experience. So, okay, I'm very big on fidelity in manuals. So fidelity meaning, are you doing what you are supposed to be doing? Are you doing it the quality and the integrity that you're supposed to be doing? Because let's admit it, we all drift, right? We all like get our degrees and we're so happy and we remember everything, and then kind of over the years we forget stuff, right? So we need to hold ourselves accountable, and if you're a supervisor, if you're a manager, you're a department leader, you need to hold your team accountable as well. But thinking from more of a clinical perspective, I've been very involved in the evidence-based practice that we offer at Wellbridge. But the thing is, I couldn't come in and say, okay, we're just gonna start at Fidelity. So all you clinicians in the room here, you need to just start following the manual, because guess what? Our manual wasn't good. So I was setting them up for failure. So instead, what we had to do was like take a top-down perspective, right? So you have to say, well, what's the program? What is the purpose of the program, and is it time limited, right? If you're outpatient, I still encourage you to be time limited. Do you want programs that are set up for patients to be here 4 weeks, 6 months, 180 days? Like, how long do you expect them to come? And have a program that they might be able to like fall into when they come to your services. For us, it was 28 days, which is perfect. 4 weeks, so we had like rotations of 4-week groups. So then what are those groups? Are they comprehensive, or are they all kind of repetitive, right? That's a big theme that we get a lot, especially in the early days of, oh, your groups are so repetitive. Well, guess what? Everyone was kind of doing the same thing and didn't realize it. So then we're like, okay, so we have the general structure, we have the groups we want all of you to do, now we have a manual. So now we need to train you all in the manual, and then we're gonna start going into rooms, maybe once a month or so, and making sure that you're all doing what you're supposed to be doing. So it's a fair way to really get at this concept. When I came to Wellbridge, I really zoned in on cognitive behavioral therapy. I zoned in on the golden poster person of therapy, which is CBT. And so what I did is I created, this is just an example. You can use this, again, this is one that got published. If you want to copy and paste me, I'm perfectly happy for you to do that. Or you can contact me and we can think up another way for you to do this in your organization. But this was a multi-year, multi-stage project where first stage was just optimizing the manual. Again, I said it wasn't that good. Like, whoever created it was actually already gone. So it kind of was one of those things that was ancient. I'm sure you all can relate to that. It's just kind of there. You're like, who made this? It was literally in a binder. And I'm like, this isn't even electronic? Okay, cool. So we spent like about a year and a half really optimizing the manual. I sat down, I interviewed every clinician. They gave me feedback on what they liked and didn't like about the manual. They told me what they did instead for the groups that they really didn't like within the manual. And so we updated it. So I spent was it last summer? All of last summer, like literally updating the manual and creating new worksheets, new handouts, everything based on what they told me. And that process is what is published over here. And again, like the bones of the manual are also in that paper if you're interested. So the next step, now we can do fidelity. Now we can go into the room and make sure that what they're doing is good. But that does take a lot of trust. Right? So that gets back to that culture at the beginning. You can't just go in and do it, because even if you plan and train, it's going to feel punitive. So you have to do it in a way that feels fair, where the clinicians don't feel called out. And then you can get to their experience, then patient's experience, and then just ongoing maintenance. So from a prevention perspective, this is very much tertiary. This is solely if you're in a treatment facility. Okay, so this is one that's really fun. This is a newer thing for us. Just because it took us a few years to get to this point. So tip number 5 are specialty programs and or groups. So this is one that might seem obvious to some of you, but it actually takes a little bit longer to get to than you might expect. So what you see here are lists of groups that we either offer or we're planning to offer, or just ideas for other groups that you could offer. So depending on where you're at, some of these could be groups, some of these could be an entire program of care for your patients, because addiction is different for everyone. We've established that everyone has their own journey to recovery, but that journey needs to also include their identity as well. It needs to be very much as curated as possible for them. So something that we've done is we have a healthcare professionals program. This has been around softly for about a year, but I've really started collecting data on it since about January. So at least in the New York area, so I'm on Long Island, so we get a lot of people from the city. We get a lot of people that had started using, especially in response to the pandemic, in response to COVID. And so we felt that we needed a very specific healthcare professional program to help everyone who was kind of struggling, who worked in the healthcare system, because we know that they tend to have different modalities of use. They're maybe diverting from work, and it's just a different pathway to use. They also tend to be a little bit more educated than maybe some of our other patients. They have higher degrees, and so they're just starting on a different level, a different playing field. And so we wanted to create a program very specific for them. So When we get healthcare professionals, they're assigned to one clinician. There's one clinician whose sole job it is to run this program. But in addition to having groups that are very specific, thank you, they also do volunteerism. They go out and about. We have a partnership with a local restaurant who lets them come eat lunch once a week on, I think, Wednesdays. They go volunteer. They can also go to the movies. So like they get, other privileges that maybe some of the other tracks don't get. But that's really to create a program that's customized to them, that's going to keep them in treatment and really give them what they need. We also, of course, offer not legal help. We're not lawyers, but we offer a lot of licensure help and things like that come up with this population. Tip number 6, this is a softer one as well, but one that I think is very important. So no matter who you are, no matter what you are, training and orientation are very important, right? So something that I worked very hard in the beginning as part of building the learning laboratory culture was I really wanted to be in our HR orientation. I was given 15 minutes. I still do it every first Tuesday of every month. I'm there at 11 o'clock to 11:15, telling people about my department, what we do, because I think every staff member at Wellbridge needs a working knowledge of what my department is doing, because even though we're there, it's actually very easy to forget that we're there, because most places don't have researchers. And so it's very important to keep reminding people that, yes, we're actively trying to close this gap. We're a very science-based organization. So I said, the culture, like building the culture never ends. And this is a really key part of it. But even if you don't have the opportunity to be part of an HR orientation, maybe you just create a job manual for your position or the positions of people that you supervise, right? That goes a long way with making everything science-based and making everything research-based. Simple things like Excel tracking sheets, competency checks. So even again, like kind of the fidelity manuals are related to this, but you could do this for any position that you had. So I have research assistants. I go in once a month and I watch them do an assessment. And I have a check sheet, and then we debrief after. Because again, we all kind of drift. We all kind of get used to what we're doing. So we need to hold ourselves accountable. And of course, case studies. I'll circle back to this again in a minute or two. But this is another really important one. So I'm a research department. I'm not a trained clinician. I still do case studies in every supervision with my team. So it's very important for everyone to have those skills of patient X presented, 50-year-old male with cocaine use disorder, and this is how he did it on the assessments, and this is what we've seen in his medical chart, and talk through it as a team. That helps break down the barriers, break down the biases, and helps us keep each other in check. Okay, number 7, we're getting there. So this is another one that is a favorite of mine and not a favorite of everyone else's. So probably because of my background in science and research, I believe in psychoeducation. So guess what? Rehab is not easy. It should not be easy. Every group should not be a process group. Some of them should be skills, and some of them should be knowledge-based. And so what you see here are a list of the types of groups that we offer, some of which I even lead. Yes, they should be interactive. Yes, they should be fun. Yes, they should be at a layman's level. But the patients still need knowledge because that's empowering when you're talking about addiction. But it shouldn't just be at the patient level. Again, we're talking at all levels of prevention. Staff need to be knowledgeable too. And you don't know which staff of yours are also at risk or what levels of addiction they're struggling with. So have seminars, right? That's something I started when I got to Wellbridge. I can guarantee you not everyone loved it, but the people that were into it were really into it, and they really appreciated that. I also do a weekly journal club with my team, and anyone can come who wants to do it. Again, the orientation, onboarding, and the case study. So these are ways that we can keep our staff and our patients involved in the knowledge around addiction. And then finally, I said we kind of keep sprinkling the genetics in there. So the last tip is one that we've kind of hinted at throughout the talk, but it's family history, right? So I developed a family history measure that we do on all of our patients. The paper is forthcoming, so I would love for you to use it, but this is one that you can't just take from the internet, so you do need to talk to me if you're interested in this one. So pretty much what we do is a pedigree on all of our patients who get an assessment, and a pedigree or a genogram. If you're a social worker, I had to learn that one the hard way. We ask all of our patients these 4 questions about They're first and second degree relatives, so people they're 50% or 25% related to. So we ask, what substance was used, frequency, if they saw their stories, or if there are problems. And depending on how they answer, that family member gets a full shade, meaning that they definitely have a use disorder, or a half shade, meaning it's probable, or a dot, meaning that they're in remission or recovery. And so this is very important because a lot of the times this type of research involves calling all of these family members and hoping they pick up the phone and doing long questionnaires with them. And that's great for a researcher who has grant money to do that. That's not great for you that has like 20 minutes to do this, right? So this is a very quick, effective way to really get at the family history of a patient. But we don't stop there. We also then turn it into a 0 to 1 number using an algorithm that goes into their assessment report. So what we tell patients is that we're not telling you anything you don't know. We're showing it to you in a new way visually, and we're giving it to you in a new way numerically. And what this score does is the family density score, meaning if it's a 0 to 1, so if it's a 0.6, 60% of your risk likely came from genetics, and the other 40% is likely environment. And this is a whole other talk in and of itself, but really what this means is that this is, again, getting back to knowledge, getting back to empowerment. There's a lot of research to show that this type of information can make a huge difference in patients' lives. So again, the family history measure is really getting at that secondary and tertiary level. So it requires some level of training. I always encourage senior staff to go over it with the patient very explicitly, and they're very into it when you go over it with them. And again, it's not telling you something new, but it's really helping them see it from a new way, and it's really complementing all of the other information that you've gained about the patient that you've shared with them. So those are the 8 tips. Those are like the action-oriented parts. So again, I hope that something kind of piqued your interest. I hope that something was interesting to you. So final thoughts, right? So like, what have we done today? So what have we done over the last 50 minutes? So we've highlighted the research to practice gap. We've gone over what it is. We've really shown how it can result in a lack of treatment and prevention rigor if it's not there. So what can we use to close it? We can use prevention science, right? So we can use a vital framework to close the gap, a framework that affects everyone, not just the patients that we immediately see every day. But how can we do that, right? So we do that using science. We do that from a very rigorous perspective. We can use assessments, we can use quality control, we can do groups, we can do psychoeducation. There's a lot that I offered, and there's a lot more, but these were the 8 that I found to be the most effective in my time at Wellbridge, and what I hope really can, be utilized by some of you today in one way, shape, or form. But I would be lying if I said this wasn't easy. So there are barriers. I want to be very clear that there are barriers. And so part of creating a learning laboratory culture, part of closing the gap, is being aware of which barriers you're really fighting on an everyday basis. And maybe there are ones that can be overcome easily, and maybe there are ones you can't really overcome right now. And so you need to turn your attention towards something else. So very common barriers in the literature, and of course, which I've encountered, which I'm sure all of you have encountered, include things like time, include things like competing goals, right? So I have my department, I'm one of several departments. We all have our wants and needs, and sometimes that gets in the way of what actually gets done. Buy-in, AKA, do people actually want a scientific culture? Do they actually want to be part of research? This is one that I'm going to admit I assumed would not be part of Wellbridge, and it was. Even despite Wellbridge being a very purposefully built, scientifically minded community, buy-in is still an issue, and I think it's probably an issue for a lot of people. Support. Yes, we need money to do some of this, right? Not grant money, but we need money to even pay our staff, to be able to get more staff, to pay patients if they want to be part of an actual research study instead of maybe more of a quality control initiative. Education, of course, as we talked about earlier, training, as we talked about earlier, and functionality. So even though there might be ideas that I talked about today that you think are neat, do they actually work within your organization? At what level do you need to maybe adapt them and make them functional? So again, final thoughts, right? So if you take nothing away, take this away, please. So just be aware of the research to practice gap. I think awareness is the #1 thing. Be aware of the gap and kind of kind of how does it play out in your organization? What are the ways in which it plays out? And actively build interdisciplinary partnerships. Just start there. Maybe you're the director of nursing and you never talk to the lead administrator in your organization. Just go say hi, eat lunch together, just like build that bridge. And remember the levels of prevention and kind of think about how you operate within them. Or if it's not you, how does your organization operate at that level? And maybe if you have the opportunity, if you have the privilege, think about 1 to 2 of the tips that we talked about today. Just 1 or 2, how could they maybe fit into your workflow? How could they fit into your department? And of course, always, always, always utilize a science-based approach, but also always, always, it's okay to ask for help. Email me, email anyone who's a colleague who you think could help with these types of endeavors. And with that, that is it. So thank you very much for your time. I really appreciate it.